Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm your host, Gillian Whiting, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr Maria Bolton, GP specialist and former president of the AMA Queensland.
Today we are joined by Dr Martin Wood, consultant neurosurgeon at Mater Private Hospital, Brisbane.
Martin is widely regarded for pioneering the use of minimally invasive techniques for spinal surgery since the early 2000s and for performing Australians' first intrauterine surgery for spina bifida.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Martin, welcome to sMater.
Thank you. Good morning.
Let's start with the basics. When we talk about robotic-assisted neurosurgery, what exactly are we talking about and how is it being used in spinal procedures today?
Well, it's the culmination of a fairly long journey, which I'll try to explain. I think if you think about what spine surgery used to be and liken it to driving someone in your car, it was very reliant on reading a paper map that didn't tell you where you were, whilst driving a manual car. So you had to change gear, you had to drive the steering wheel, you had to apply the throttle. And it was very much, you had to figure out where you were based on things that were around you by exposing all the spine and looking at it. That meant that you had to perform wide exposures, strip a lot of the soft tissues off the spine, really to figure out what your landmarks were and where you were going to put implants into the spine. And then about 20 or so years ago, we started to have the availability of what's called stereotaxy for use in the spine. That was a big leap forward and really then takes us forward into, if you imagine that in your car, you've got a GPS, you don't need to read the map anymore. But that GPS just tells you where you are. It doesn't really tell you where you're going to help you get there. So you still got to drive the car yourself. And so you could, because you knew where you were, you didn't have to expose so much of the spine to actually see it. So you could do surgery, putting implants into the spine through smaller cuts. But you still were responsible for manipulating the instruments yourself and guiding them in the right direction. And you could get that wrong. It was very accurate, but not 100% accurate. The robot really takes that a step further, such that now you can imagine as if the car is operated by the GPS navigation system. It knows where you're trying to go because you've told it, I'm going from here to here. Like when we get in our cars today and we tell Siri you want to go somewhere and she plans a route for you. And the robot, if you like, controls the steering wheel. So it knows where you're going and directs you. You still have to have your hands on the wheel or it won't work. You still have to apply the throttle, so you still got to be there physically involved in the loop. But you've told the robot where you want to go, and it then puts you in a position such that you go exactly to that point. It's not yet an autonomous system where you can just get in and say, I want to go from this place to this place with my implants, and it will do it for you. It's not an autonomous robot. The surgeon still needs to be involved in the loop, but it's robot assisted in that it almost replaces your non-dominant hand, which you used to use as a guide for putting things into the spine. And that rigid robotic guide that you've made a plan for, you can't overcome that. See, it's very, very hard to put implants in an incorrect position. You don't need to see the spine at all. So it really means you can do quite complex surgery through very small cuts with a lot less cognitive burden as a surgeon.
Revolutionary, obviously, with so many procedures.
Absolutely. And it's really, I think there was a concern when it first came on the scene a few years ago. Was it just going to be a marketing tool? Hospitals would buy robotic systems and use them to attract patients because it was great technology, but it wouldn't actually change the way we saw the utility with which we could do a surgical procedure. But since getting one, all of us have been blown away by just how much it's improved the surgery that we do, how much easier it is to do the surgery, how much less thinking you have to do about it, because really the robot just, it affects the plan that you've made, and it's very, very accurate. So it's a great step forward, and we're all very excited to have access to it and be able to use it.
What robotic technology is currently available to neurosurgeons in Australia, and how does it improve the accuracy and safety for patients?
Well, there are different sorts of robots. There are cranial surgery robots that you can use to guide surgical procedures in the head, often used for biopsies or for implantation of electrodes for people who've got Parkinson's disease, or if they're having epilepsy surgery and you're guiding implants to record epileptic signals in the brain. And then there are the spine robots, which I guess is what we're more talking about today, of which there are a couple of more common ones on the market. They're not widely available in Australia yet. They're becoming more available in some of the private hospitals. The system that we got, the Globus Excelsius EGPS system, was the first in Queensland here at the Mater, and we've been extremely impressed with it. So we're very fortunate here. We've got a cranial robot and we've got a spine robot. You can get robots that will do both, but then there can be competing demands for them on the same day. So we're very lucky we've got a cranial designated robot and a spine robot used for different things.
How common are they in tertiary hospitals around Australia? Is this that we're seeing them more and more?
We are. I think in the public system that they're not widespread at all yet. They're becoming more common in the private sector. I think since we got ours, there are probably 2 or 3 others now in Queensland. So it's certainly becoming seen as the next standard of care and taking surgery forward that bit more in terms of accuracy and safety.
The world's first robotic-assisted neurosurgery was performed in 1985 when a stereotactic brain biopsy was carried out using a modified industrial robot. This procedure marked the beginning of robotic applications in neurosurgery and was conducted to improve precision and reduce the impact of hand tremors during delicate intracranial procedures.
What kind of cases are better suited to robotic-assisted surgery?
It's really anything where you're putting an implant into the spine, which increasingly is how we manage spinal pathology. So we're talking about putting titanium screws into the bone of the spine in patients who have got loss of the normal height around nerves. The nerves are being compressed and you want to restore the height of the spinal segment, or patients who've got malalignment of the spine or instability of the spine and you need to provide stability or restoration of normal alignment. It's very hard to do that without putting things into the spine, putting implants into the spine. And it's really applicable for anybody who's having any sort of implanted spine surgery, which is here at the Mater would be maybe a dozen a week. So it's quite common. You can use it for other cases where you're not putting implants in, but it's really then used more as a navigation system without the implantation capacity. But it's very useful for that too.
What should GPs be aware of when we're referring patients for robotic-assisted surgery, or, is there anything to look out for when patients come back to us after the surgery?
I think I would see it as being applicable to anybody who's having spinal surgery. There's nothing different about it in terms of the patients you manage. And minimally invasive spine surgery, if anything, is better for people who were previously much harder to operate on. So patients who are obese, who have diabetes, who are more prone to getting infections after surgery. Because you're making very small cuts, you're not disrupting muscle tissue, those patients are much less at risk from those sort of complications than they were previously. So really in a way, patients who are less ideal for open spine surgery are better for robotic surgery because you avoid a lot of those complications because the cuts are smaller, they get less pain, less bleeding, they mobilize faster afterwards, and you really reduce the complication load.
Is there any particular information that you would like to see on GP referrals that may assist you in caring for our patients?
The important thing that we'd like to know as neurosurgeons, it's often sort of quipped that all neurosurgeons do is compress nerves. Whatever operation we do, whether it's on bones, whether it's sucking clots out of the head, really all we're doing is decompressing nerves. So it's important for us to know, does that patient have nerve compression symptoms? So do they have arm pain? Do they have leg pain? Rather than just back pain. So the majority of people with back pain alone, we can't help with surgery. That's certainly very well accepted. There are certain caveats to that, but the majority of people with back pain are not generally surgical candidates. So if a patient has what we call radicular pain, so pain in the arm in the case of a neck pathology, or pain in the leg, or one of the other of the legs for lumbar pathology, we're much more likely to be able to help that patient with surgery.
You've talked about how more common the robotic surgery is, and the robots are making a huge difference. But what about patients in rural and remote parts of Queensland? What about access and equity for them?
Yeah, that's a really tricky one. Neurosurgery really, because it's costly, it tends to be based in capital cities or metropolitan areas. So patients from regional areas get a bit of a raw deal in terms of access to neurosurgery, particularly when things are urgent, because time is often of the essence. If it's a brain problem from trauma or a tumor and there's pressure in the head, you really have to get on and alleviate that quickly. So it is a problem, and it's always something that we wrestle with in terms of planning neurosurgical services. The way things are at the moment, if we're talking about the spine robot, we're very fortunate that Mater has a network up and down Queensland, really across the length and breadth of Queensland. So patients can be seen in regional clinics, and the practice that I work with here certainly offer regional clinics up and down Queensland, and they can access care in the local community with a visiting neurosurgeon, so traveling from here.
So you've been travelling up and down the coast?
Yeah, in my case, I've had a lifelong passion in aviation, so I've had a plane for a couple of decades and used that to travel to and from clinics, which, was good for me, but also good for the patients. So we can see them in their hometown, whether it's Rockhampton, Bundaberg, Hervey Bay, Mackay, and they can come down and have surgery here at the Mater, where we've got all the bells and whistles. Whether things advance to the point that, if robots become more autonomous and you can operate them remotely, maybe it works out better financially to have just a robot in a regional town and a surgeon in the capital city who can then run a robotic case remotely. We're a long way from that yet, but that's really the sort of the pie in the sky destination, perhaps, for regional communities.
It would be great if everybody had access to this kind of equipment. How would that be possible?
Well, I think the main reason why it's not more widely available is the cost. These are very expensive surgical systems. We're very fortunate here at Mater. There's very strong community philanthropy to the Mater Foundation, and that they were able to support the acquisition of all of our recent technology. So the cranial robot that I mentioned, that was supported by philanthropy through the Mater Foundation. The Excelsius eGPS robot that we use for spine, again, very generous philanthropy to the Mater Foundation. And we've had just installed very recently a new imaging system that provides that 3D imaging of the patient's spine that we then use as the roadmap for the computer and the robot. And that's just been installed here at Mater. And once again, expensive but very useful piece of technology, really revolutionizes what we do. And that was also supported by philanthropic donations through the Mater Foundation. So we're exceptionally grateful for that community support.
Can you talk more through what that machine is and what does it do and how useful is it?
Yes, of course. So for a long time, to try and replace what you see with your eyes, which meant having to expose all the bones of the spine, with radiological pictures that you could then make smaller cuts with. So you're sort of seeing through the patient's skin, if you like, which is what radiology does. Initially, we had X-rays, which are two planes. They're in 2D. They don't give you a three-dimensional perception. So it kind of works, but it's difficult. Going back to the, driving while changing gear sort of analogy. And then the real leap forward was using a CT scanner in the operating theatre, and mobile devices to do that came on the market about 20 years ago. And a thing called the O-arm. We had the first O-arm in the Southern Hemisphere in 2007 here at Mater. And that really kickstarted this whole minimally invasive spine robotic progression journey that we've been on. That technology has been advanced and improved upon. And so the latest and greatest version of that is a thing called the E3D, again made by a company called Globus in North America. And we've just received one of those here at Mater, which is a great leap forward in terms of the footprint in the theatres, how useful it is, how maneuverable it is. The footprint around the patient and the quality of imaging is much better than what we had before. And it just adds that next little layer of accuracy, safety, and efficiency to what we do here at Mater.
As a patient, having access to the fabulous makes such a difference. Any financial? Does it cost me more to get the robots?
No, it doesn't.
Okay.
So we take the view that the technology is there for everybody, and we treat public patients and private patients here neurosurgically at the Mater, and it's available to everybody. It costs no extra to have the robot used in your surgery than if you don't have the robot used in your surgery. So we use it on everybody who it's suitable for. The devices are expensive. There is no recognition of that in the Medicare schedule fees and the health fund rebates. So given that that's the case, if there was an increased cost, it'd have to be borne by the patient, but we don't charge any more for their use.
According to Grandview Research, the global medical robotic systems market, which includes everything from pharma robots and robotic prosthetics to surgical robots, was valued at $25.56 billion in 2023. It is projected to grow to $76.45 billion by 2030, representing a compound annual growth rate of 16.5%.
For patients who are travelling, I used to live in Mackay, so for patients who are travelling, for example, from Mackay to have spinal surgery, how long would they be in Brisbane for?
Depends a little bit on what they're having. If they're having if they're having non-instrumented spine surgery, so they're having, for example, a lumbar decompression, what we used to call a laminectomy or a discectomy. Usually they're in hospital for 23 hours or less. So they come in on the day of surgery, have the surgery performed, and then they're good to leave hospital early the following morning. the only problem is the airlines haven't quite caught up with the concept of less invasive spine surgery and the fact that patients are not as sore afterwards. They could easily fly home the day of discharge. So the airlines often make them wait a bit. So we often say, have you got someone you can go stay with for an extra day because you may not be able to fly home, even though we sign off their airline forms. But in hospital, often less than 24 hours. Now, if they're having implants put into the spine, in the lumbar spine, typically they would be in hospital for 2 nights post-operatively, so after the day of surgery, which is a huge improvement on the old sort of 7 to 10 days in hospital after an open spine operation, which is a much more painful ordeal for them.
Are these advances in surgical techniques opening up these procedures for more patients? And where do you see the future?
I think they are. It certainly makes this sort of surgery where you're putting implants in the spine much easier, and much easier from a surgeon's perspective in terms of learning how to do it, because you're not struggling to read the anatomical map while you're driving the cars, to use that analogy again. But it's also much easier for patients. So patients who are a bit more elderly or infirm, got comorbidities, maybe got some negative factors that might have weighed against them previously and possibly excluded them from surgery. Now they can have surgery that's much less invasive, it's much less damaging to their tissues, much less of an insult on their cardiovascular system. They go home faster, they get back to their normal activities faster. So it does certainly widen the envelope of who can have this sort of surgery. Where are we headed in the future? I think ideally it'd be nice not to operate on so many people with spinal pathology, and maybe we'll have regenerative techniques and technologies that can restore disc health or restore ligamentous health, that you don't have to decompress the nerves physically. Maybe that would be great, but we'd all be out of a job. In terms of where the robotic technology is going, I think it's improving year on year, and we're starting to see some artificial intelligence applications where instead of you telling the robot what the surgical plan is that you want as a surgeon, it can analyze all the data that it's got from all the L5-S1 fusions, for example, that might have been done in the last 3 years, and there'd be millions of them, and suggest a plan. So saying, if you put into the system, this is what the level I'm operating on, it'll suggest a plan or a couple of plans. You go, yep, that's fine, that makes sense. That we're starting to see already with some of the new software updates. And then the progression of autonomous mechanical activity of the robot really then would be the next thing. How much does a surgeon still need to do? You can build cars without humans needing to do anything to the robots. You just run a program and the robot builds a car. We should be at the stage where a robot could put a pedicle screw into somebody's spine. But really, for a lot of reasons, most of them due to human confidence, the surgeon still needs to be involved in the loop. But I think in time, that probably won't be the case. Same as we'll have self-flying aeroplanes and self-driving cars. It's all just the progression of technology.
It's evolving so quickly, it seems to be. Where's the research happening? Is much done here in Australia, or are we being guided by global leaders here?
I think we just don't have the population density here to really be drivers in terms of the technology development. The robot,
where's it coming from?
It's coming out of North America principally, but there are also very active robotics projects in Southeast Asia, Korea in particular, and in South Korea, it's an offshoot of the car making industry. They've clearly got huge car building industries there, and the automotive construction robots are being adapted and modified for medical use. So it's a fascinating field. And I think, like everything in the modern world, the advances just happen faster and faster, and where we'll be in 5 years' time is probably hard to comprehend.
What about that relationship between primary care and specialist surgery? How will that change, do you think?
Well, I think we're seeing increasing ease of access of surgeons to general practitioners. So whether, the GP I often get text messages from GPs saying, hey, can you have a look at this patient's scan and just let me know what you think, just send me a text back. We couldn't have done that really 5-10 years ago. The GP would have rung the practice, and I may or may not have been there, and they'd leave a message, and I may or may not have called them back, and there'd be this run around the houses trying to get messages to and from each other. But ease of access and communication is phenomenal now. Some practices are experimenting with GPs directly booking appointments on their practice software. We're not doing that yet, but that's seems a logical step, that the GP has visibility over where a patient can be slotted in if they're urgent or less urgent. So I think communication is the main thing, and just the ease with which we can look at patient images as well. Patients don't have to lug around envelopes anymore and turn up and go, oh, damn, sorry, I left my x-rays at home, or they're on the bus, or there's no physical films anymore. It's so much easier. I can look at x-rays on my phone. So really the technology that we all take for granted day in, day out, mostly on our phones and our laptops is changing the way we practice medicine.
What advice would you give the next generation of neurosurgeons?
It's difficult because I think they're going to be practicing a very different specialty to the one that I grew up in and my mentors grew up in. I think I would say to them to live in the moment and to make sure they make time to enjoy the journey through their training. I look back on my training years as some of the best years of my career. You know, the work just came in and you operated on it and you learned and you interacted with patients and you didn't have to do quite so much hard yakka to generate the work. And then you go into private practice and it's all on you and you've got to generate the work for yourself. And it's not less enjoyable, but you don't realize how good it was when you were training and what a fantastic experience, what a great privilege it was. So I would tell them to enjoy the training experience, not be too focused on where they're going, because the journey's great. But always, and this is sort of becoming better as time goes by anyway, just to try and make time for life as well, not to get too focused on being a neurosurgeon. You know, neurosurgery is your job, but you can have a life as well. And, you know, excluding the other things in life because of your job and being so focused on it is often to their detriment. So work-life balance is a lot easier to achieve. It's often spoken about glibly, but I think it is important. Not to say don't take your job seriously, but it's a job and there's a lot more to life than your job.
And I think that goes for every doctor out there, not just neurosurgeons.
Yeah. But it's very different to the previous model, you know, generations older than me, where you were a neurosurgeon and that sort of defined you until you dropped dead at 80 when you were still working.
We want to know a little bit more about your life now as we wrap up. We'll introduce you to our little segment called The Checkup. So this is to get to know you a little bit more as well as your professional strengths. So Maria's got 5 quick questions for you. You ready to go? Okay.
Who's the most underrated member of the hospital team?
In terms of the people that I interact with regularly as a surgeon, I would say it would be the orderlies. Whether on the wards or in the theatres, they get patients where they need to be. They make stuff run. They make stuff run on time. When you need something done, an orderly appears and helps you do it. And we wouldn't get stuff done. We wouldn't get it done on time without the orderlies.
They're great multitaskers too.
Yeah.
What's your secret superpower?
I don't know that I have one.
Flying a plane, maybe?
Yeah, that's not so hard.
Isn't it?
No harder than driving a car. There's less to crash into. I think my secret superpower these days is being able to take a positive attitude to things in a way that I might not have done in the past. Always be grateful for everything.
What was your first concert?
I can tell you what my first record was. When I had a record player when I was single-digit ages. It was a single for Flash Gordon, the theme tune to Flash Gordon by Queen.
Right,
Yeah, remember that one?
I do remember
That was my
one.
first record. First concert, I couldn't remember.
Flash Gordon is great. If you could impart one piece of knowledge on a medical student, what would it be?
One piece of knowledge. I don't know that it would be about medicine necessarily. I think it would just be what I was alluding to before, just always be grateful that you're in a very privileged position, and no matter how crap a day you're having a better day than the person on the other end of the scalpel or the needle or whatever's being done to them.
And who was the last person you video called?
Probably somebody in my other job at Avant. I work with Avant, medical legal insurer, and it was probably just a very mundane video call about somebody getting into trouble about something. Nothing exciting.
Martin, thank you so much for joining us. It's been absolutely fascinating to see where we're headed really with robotic-assisted surgery. Thanks so much for joining us on
Pleasure.
sMater.
Enjoyed it. Thank you.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.